All right.
Well, welcome everyone. We're excited to have you all with us for this evening's webinar, Revolutionizing Sexual Wellness, a practitioner's guide to autologous platelet-rich plasma therapy. Tonight, we are very fortunate to have two esteemed guests on the panel, Dr. Anne Truong and Dr. Ariana DeMers. They'll discuss implementing platelet-rich plasma in the correct doses for sexual wellness, the biopsychosocial impact on sexual dysfunction, and the business of orthobiologics, all of which will be followed by a Q&A session. To make this webinar as interactive and beneficial to you as possible, please load all of your questions in the Q&A chat at the bottom of your screen. Again, we'd like to welcome Dr. Anne Truong, who is a board-certified physical medicine and rehabilitation physician with a specialization in regenerative men's health in Fredericksburg, Virginia. Recognized for her contributions to the field, she is a best-selling author and an international keynote speaker on the application of biologics. As the sole founder, owner, and president of Truong Rehabilitation Center, Dr. Truong continues to advance the field of regenerative medicine and sexual wellness. Dr. Ariana DeMers is a board-certified, fellowship-trained orthopedic sports medicine surgeon. She is the past president of the Interventional Orthobiologics Foundation and is a sought-after educator and trainer in orthobiologics and ultrasound. She has successfully transitioned her rural practice away from commercial insurance to focus on holistic orthopedics. She founded Restore Orthopedics and Sports Medicine, a center dedicated to providing patients with unbiased diagnoses and comprehensive discussions on both non-surgical and surgical treatment options. At this time, we'd like to go ahead and pass the time over to you, Dr. Truong.
Okay, thank you. All right, thank you for having me here. Great to see everyone, Lauren and Dr. DeMers. So, are you guys all ready to talk about sexual health, especially at night? Right now, because I am. I just went back from another webinar to here, so I'm all webinar for you guys. So, can I share my screen
Yeah,
now?
absolutely.
Okay. Says sharing's not turned on. Hosts need to give me permission to do that. It said the host isn't allowing multiple presenters sharing for this webinar.
You should be able to go ahead and grab that now.
Okay, great. Okay. Okay. Let me know if this is showing on your screen. What screen is showing? The one that says, is it a one slide or the presenter view?
It's the presenter view, Anne.
Okay, hold on. Let me swap. Okay. This better?
That's perfect.
Perfect.
Okay, wonderful. Okay. Okay, so it's gonna seem like a lot, but I wanted to give you an introduction to why sexual health and biologic are just a perfect marriage together. And okay, here we go. Okay. Right, I have nothing to disclose. So an overview why sexual health is health and why and then we're going to talk about the science and the research on biologic for sexual health and just touch a little bit on shockwave therapy and the multimodality approach to sexual wellness. I want to start first with a story and why I do what I do, why I'm so passionate about what I do. So my history is I'm really interventional pain management, and I've been doing that since 1997. And I went to med school when I was 10 years old, right? So, but I've always thought about, okay, this is what we're gonna treat pain. That's all the path we're gonna do. So, and then I met Ed in 2014. At that time, Ed was 70, right? And he like limped into my office and can't walk and then he was in a lot of pain, and he said, we were discussing, he said, at 70 and my wife just passed away, I have a girlfriend right now and sex is important to me, and I know that you do pain, but is there any way that you can help me be able to have sexual activity again now that I'm dating and I'm at 70 again. I really want to live. So that's what kind of started my journey on sexuality, because I was like, you know what? If I can do PRP and biologic into the spine and the joint, why couldn't I do that to the sexual organ? It works the same way. And in fact, it's probably more forgiving. And that's what dived me into the this field, and I do what I do. So, and Ed, I treated him. He was one of my first patients and still is my patient. And he is now actually over 82. And for him, doing it 3 to 5 times a week is the par for him. And I hope that will be an inspirational story for all of us. And oftentimes, if I'm not on par as much as Ed, then he is my hero. So ED, erectile dysfunction, has been around since 2600. And everything started revolutionizing more when Viagra was introduced in 1998. As you all know, Viagra was originally invented for blood pressure, to control blood pressure, but they found out that one of the side effects was erection. And then Cialis and Levitra came out in 2003. And sexual health, if you look at it, is really more biopsychosocial. It all interacts. It's not just sexual health. It's involving mental, physical, and sexual as well. So, and there's multiple research that has shown that ED is related to cardiovascular disease. According to a study by Thompson, 2005, they looked at 4,000 men, and 57% of them had ED at 5 years. So what that means is that if you have ED, is really a warning sign for cardiovascular disease down the road. All right. So ED is really the warning sign. And then in a study in 2003, that if you're symptomatic, if a man is symptomatic with cardiovascular disease, half of them actually have ED, whether they know it or not. And usually ED presents about 40 months before angina. And ED is an undiagnosed prediabetes and diabetes. So in a study by Tucker, looked at 1,900 men, and ED is associated with increased risk for prediabetes and diabetes. So essentially, if you have a man that has ED, most likely 30% of them will progress to have diabetes. And that ED is the first sign of depression and anxiety in a study in 2005 that looked at, I believe it was 2,500 men. The men with ED are more likely to have anxiety and 3 times more depression. And that ED is associated with comorbidity that you see here. The number one is alcohol, and then followed by BPH and smoking, diabetes, high blood pressure, and coronary artery disease. So if a man has these comorbidity, most likely he will have ED as well. And then according to a health survey in 2022, looking at 1,500 men aged from 18 to 80, 40% of them have sexual health issues. Let me move this out of the way. Okay. Oh, I'm sorry. And that they're not discussing it with their doctor, or they're discussing it with their partner, and they're really suffering in silence. And so sexual health is the barometer of general health. All right. Sexual health, the barometer of overall general health. And this study by Lallman in 1999 that looked at men and women, 1,400 men and 1,700 women. It really kind of, what I'm trying to show is that the prevalent that women, 43% of women have sexual dysfunction and 31% of men. I think it's about the same. But again, this study was done in 1999, COVID, and that the endpoint is that sexual dysfunction is an important health concern. And then now there's the recent study in 2022 looking at ED and COVID. We know that COVID is raises inflammation of the endothelium, it shows that men presenting with ED after COVID will have underlying endothelial dysfunction and cardiovascular issues. And now with the rising of vaping, marijuana use, maybe decreasing smoking, but I'm seeing more of CBD and vaping. You'll probably see more in prevalence of sexual dysfunction. Also, sexual dysfunction is associated with antihypertensive, antidepressant, antipsychotic, anti-androgen recreational drugs, and opioid pain medication. And that men and women in their 50s are actually having more sex than teenage male. The endpoint is sexual dysfunctions related to metabolic disease. Baby boomers. So baby boomers, there are 76 million of them living right now in 2024. And baby boomers are currently at 57 and 75 years old. And baby boomers are the largest living generation until 2019 when they were overtook by millennials. So, but the reason why I presented this, because baby boomers have about 39% of the power in American society, more so than any other generation. But also, guess what? They're also more at risk for ED. And I'm going to show you, because ED is it's present in 50% of men over 50. So why am I talking about this? Because there are studies that published by Giannotti in 2021 shows that good sexual energy or sexual function, decreased stress, decreased depression, decreased pain, decreased heart disease, decreased incidence of cancer, and that twice-weekly relations decrease incidence MI by 50%. It also burns calories, increase longevity, increased sense of well-being, increased immune function, increases joy, increases bladder, self-esteem, sleep as well. So there's multiple reasons why sexual function and energy is beneficial for everyone. And that when there is a sexual dysfunction, it is a couple's disease. So I don't know if all of you are familiar with platelet rich plasma or not. I'm just going to touch very briefly upon it and just say that, platelets come from a megakaryocyte. It is involved in tissue healing and coagulation, doesn't have a nucleus. It has these alpha granules, which then release these growth factors. So when PRP is injected, these growth factors are released, and it activates cellular response such as angiogenesis, new cell proliferation, and migration of stem cell to the area, and really involved in the production of extracellular matrix protein. And along with this, I don't know why I keep switching back and forth. I apologize that. So with the Apex PRP machine, you're able to get these growth factors that come from the platelet granules that produce new blood vessel, new cell that can help with cell growth and turn stem cells into the tissue. So let's talk about a little bit about women sexuality. Prevalence about 43% of women over 50, but unfortunately, only 9% of women have discussion with their doctor about sexuality. And that adult female population, they have 43% difficulty, but they're only talking about it. So they're also suffering in silence. So men and women are suffering in silence. And I just want to touch upon that there are 4 classes of sexual dysfunction: hyposexual disorder, arousal disorder, orgasmic disorder, and dyspareunia. And that female sexual physiology is similar to male, but a little bit different. It's a vasocongestive and neuromuscular, is under autonomic nervous system, which is the parasympathetic and sympathetic. And that really, the key to this is that the sexual response starts in the brain, where that releases acetylcholine, VIP and nitric oxide, which then stimulate vaginal blood flow. Talk about the G spot or the Grafenberg spot that is located halfway between the pubic bone and the cervix, and it's part of the clitoral vaginal network, and it's a variable spot in women. But the reason why I talk about that, because that's the area that is concentrated on the treatment when we are using PRP. A little bit about the anatomy between the clitoris and the penis. So the penis is, get my laser here. Okay, is the one on the left right here, and the that's the penis. This is the clitoris here. But most people think, oh, maybe clitoris is just that knob that you see. No, it's not. It's actually 4 inches long, and this is what is visible. But it looks like a wishbone. It goes in the back, and then it splits along the pubic rami here, as well as to have the vestibular component with it as well. So this is like the glans, and this and the corpus cavernosum, and then the crura of the clitoris. And the reason why I'm showing this picture is that it's just not about the clitoris and not about the penis. It's also about the pelvic muscle, which are the two things: the ischial cavernosus muscle, as well as the bulbospongiosus muscle, or bulbocavernosus. I mean, these are the muscles that are also augment with the clitoris or the penis for arousal, for increasing blood flow, maintaining and erection. And so I touch upon it. So when we do PRP treatment, we inject PRP into the clitoris and the G spot. And just a little kind of sagittal section of what the G spot is, which is really a potential space. So the PRP is injected into the potential space between the right here with between the urethra and the vaginal canal. So I just want to show research here that you can look on your own, that PRP injection into the vagina is safe. There's no report of granuloma, infection, or any other serious disease. And that PRP for gynecology, it will increase sexual responsiveness. It increase fibroblast growth, gland growth. So that's why it's very helpful in lubrication, very helpful in increasing sensitivity. It's helpful with new neuronal growth, and as well as arousal and orgasm. With this study by Daywood, review all the clinical uses of PRP in the field of gynecology from January 2000 to December 2017, and it's really now PRP is really considered the new therapeutic modality for female sexual dysfunction that are refractory to conventional treatment. This study by Nito in 2017 looked at 68 women. Average age is 63 years. They have lack of lubrication, sexual dysfunction such as low libido, arousal, and dyspareunia. They had PRP injected 2 months apart. I think it was 2 injection, really only 8 cc of PRP injected into the skin glands and into the G spot. And what's important is that this improved urinary stress incontinence and overactive bladder, and it helped with lubrication and arousal. Study by Runnels in 2014 looked at 11 patients. And what they found out was just 4 millimeter PRP injection to the G-spot. And the clitoris, they have 71% of them improve in the female sexual dysfunction, which is look at arousal, desire, and orgasm and satisfaction. So this is kind of like a review of PRP literature that can be used in gynecology for lichen sclerosis, vulvovaginal atrophy, mid-urethral sling, sexual dysfunction, dyspareunia, even interstitial cystitis. That's pretty awesome. But you're not injecting in the bladder, you're just injecting to the G-spot, but it also has kind of retrograde effect as well. Post-episiotomy pain, vaginismus, pelvic floor pain, pelvic floor prolapse, according to the severity of the prolapse, urinary incontinence, which is a hit for that, endometrial reproduction cycle. It's only one study that showed that, and ovarian folliculogenesis. So these are all the references I put on here, review. Individually, also, this one study shows that it can also be helpful with mesh pain as well. And I want to include this study here because vulvovaginal atrophy and breast cancer for survivor patients are very, very prevalent. And this is probably the one I do the most for women, is that they can't take hormones because their breast cancer survival, and doing PRP injection in just the G-spot and the clitoral injection, it actually will improve with vaginal dryness and dyspareunia. So it is a home run for these females that are suffering with lubrication. So I wanted to mention that if you are treating a woman, and that no woman should be living with painful intercourse, because it can be so easily treated and reversed within days, literally within days, from 5 days to 7 days, with topical hormone plus PRP. And these are more references here. And then we're going to talk about the men. All right. So I took this picture at Moab. When you got any of you guys been to Moab, the Arches National Park? Well, I love it there. And so doing what I do, I look through the lens of what I do. So it's a marvel of engineering. The penis capable of increasing blood flow by a factor of 40 times over baseline within seconds. Now, the vagina, it doesn't need to increase for 40 times, about 3 times. So what is ED? ED is really defined as the persistent failure to generate sufficient penile body pressure to achieve vaginal penetration, and or the inability to achieve this degree of penile rigidity until ejaculation. So what this means is that you can still have an erection and still have ED. It's just not as rigid, and it's not able to be able to maintain until ejaculation. So most men think that, well, if I have an erection, I don't have ED. It's a degree of the rigidity as well, and that it is a smooth muscle problem. And that it is a small blood vessel problem. And as I alluded to before, ED is very common. And according to Kandel in a review in 1995, 150 million men had ED in 1995. They're projecting by next year, which is only in 3 months, that it's going to be estimated to be 300 million men worldwide will have ED, but this is in 1995, pre-COVID. So I'm thinking that number will be a lot more than 300 million. And this is a landmark study by Feldman in 1994, which shows that the older you are, the more likely you're going to have ED. And if you're 50 years old, 50% will have ED. And that the older you are, the more the severity of ED. As you can see here, the severity, which is the purple box, is more as you get older. So what does this mean? This really means that we need to be intervening for men with ED around this age right here, about probably 50, because at 50% of them have ED. The earlier that we treat men with ED, the better the reversal before they start having arterial damage and claudication. So ED, what this a study shows is an unmet medical need, and because most men want a cure, they don't want to take a medication, and in fact, medication is almost 40%. Like ED medication, like Viagra and Cialis, it's 40% non-effective at this point. So it's an unmet need. And so the nerve supply for the penis very similar to the female. It's a parasympathetic autonomic nervous system is responsible for erection, and sympathetic nervous system is responsible for detumescence and ejaculation. And you also have the somatic dorsal nerve on the penis as well. I know this is kind of like an overwhelming slide, but the point I want to stress here is that since erection, the penis is a smooth muscle, that when the penis is flaccid, it is in contraction. So the smooth muscle is actually contracted when it is flaccid, and that when it is when the penis is in an erect state, the smooth muscle is relaxed. I know it's kind of counterintuitive when we think about somatic muscle, like the biceps, right? When we're contracting, we're using the movement, where the smooth muscle of the penis is the opposite. But that makes sense because the smooth muscle has to be relaxed so that way it can get filled up with blood. When it gets filled up with blood, then it can have increased blood flow. Okay, and this is the study that is a really good study that describes the mechanism of erection. So this is a picture that shows that when it's flaccid, the smooth muscle is contracted, and that there you don't see the blood vessel engorge. But when it's erected, the smooth muscle is relax, and then the blood vessel is engorged, and that is the mechanism of increasing blood flow to the penis. And that ED pathogenesis is multifactorial, is vascular, metabolic, neurologic, local, hormonal, drug-induced, psychogenic, and lifestyle factors, as well as other systemic condition. And that what I'm trying to say here is that ED is a metabolic disease. It is related to diabetes and dyslipidemia, high blood pressure, and inflammation, which then contribute to lower testosterone, which then contribute to decreased sexual function, and then the cycle repeat itself. And why ED medication like Viagra doesn't really treat ED, right? Because Viagra works by relaxing the smooth muscle here, by increasing cyclic GMP. However, ED is the decreased blood flow problem, which starts in the endothelium, which is proximal to the corpus cavernosum muscle, and endothelium is affected by metabolic conditions such as high blood pressure, diabetes, cholesterol, obesity, and smoking and drugs. So treatment should be here where the decreased blood flow restrictions start, not here. So that's why when men take Viagra, they're ignoring the cause of the problem. The cause of the why they have ED worsen over time, and that's why over time it doesn't work for them anymore. So this study by Pulias and shows that intracavernosa injection with PRP is safe and effective. And they look at 60 men who had mild and moderate ED. So this is one of the landmarks, the landmark study in 2021. That another study by Matt in 2018. It's a small population, 17 men who received 2 injections of PRP up to like 9 cc. That's 1 month apart. They've also have improvement in their ED as well. And this a couple of these studies here also shows PRP that 3 weekly injection of PRP. I don't do weekly, but I do monthly. And also that PRP is also effective for ED as well. Just a brief slide here comparing sildenafil, which is Viagra, and intravenosa PRP injection, right? So Viagra, as we know, have side effects. The most common side effects is facial flushing, stuffy nose, indigestion, and headache. No spontaneity. That's the number one reason why men come and see me, because they take Viagra if they can't be spontaneous, and if they have heart cardiovascular disease or prostate problem, they can't take the Viagra, and then after a while, they develop a tolerance to the medication. Versus intravenosa PRP injection, natural, no side effect, and satisfaction is 85% compared to Viagra at 70%. More research study here. I want to touch briefly on just shockwave therapy emergence since really 2017. I've been doing shockwave since 2018 when we are able to have the focused shockwave in the US. And I'm just going to show you very briefly a couple of landmark studies. This one by Vardy. And he looked at 20 men with vasculogenic ED, no longer responsive to Viagra. This is important. No longer. I mean, they have pretty severe to moderate ED, and they receive only 2 treatments per week for 3 weeks, which is 6 total. And that these men improved, and they did not even get PRP injection on top of this, and they've improved. No longer require medication for erection. Another landmark study here by Vardy as well that look at the efficacy of shockwave for ED as well, and they saw that it was that 50% of men got off of their ED medication. So what is shockwave? Shockwave therapy, I'll show you the picture of the machine. Essentially, it is low energy shockwave, which induce the endpoint is angiogenesis, but because of the energy of the shockwave, it induces shear stress, and then you have intracellular and extracellular response, which then increases nitrous oxide, which then increases growth factor, and then you have angiogenesis. This is just a more detailed slide and what's really kind of going on, and that why I use shockwave therapy along with PRP injection. And this is just a study that just show what I just show you there. More study showing that shockwave do actually increase blood flow to the penis. This is without PRP. So there's various shockwave devices: electrohydraulic, electromagnetic, and piezoelectric. And the top one is the focus, and the bottom one is the radio shockwave. I use the radio more for pain. For pain, I use focus and radio, but then for sexual restoration, I will use the focus. So this is another kind of machine here as well. And the point that I want to point out is that shockwave therapy is cellular regeneration versus what you hear about lithotripsy, which is also shockwave, is really more high energy here. And more studies, more research as well. This one, this one is, it also shows that shockwave therapy increases the hemodynamics. So if you're going to do a Doppler test on the penis, it increases more blood flow. At this point, it's another study that says that men that have failed ED medication can receive improvement with shockwave therapy. So I want to include this because a lot of people hear the word Gainswave. Gainswave is really the radio shockwave, which is down here. So this is the focused shockwave, different energy. It's more cellular. There was a study by Sandoval that looked at efficacy of radio pressure wave. So the radio is not a shock wave, it's pressure wave. It's really by pressure, and it makes it sound like what is it, a drill handle. She looked at 80 patients with moderate ED, and they all receive 6 weekly sessions of radio shockwave compared to sham. And these patients also had 25 milligrams of sildenafil. But what it shows is that at 6 weeks, there was no difference between the two groups with sham versus the one that was treated. Again, the radio has not shown to improve ED, but focus shockwave has shown that. Very briefly, a couple of studies by Giuliano that looked at Botox for ED. The intracavernosal injection with Botox increase. It actually works on relaxation of the corpus cavernosum, which as I talked about earlier, that increases more blood flow. This is another study as well, which show improvement with Botox out of 18 out of 35. So the endpoint is that to restore sexual function is really a multimodality approach. I have shown you studies that looked at one approach, but what I recommend is for sexual restoration that the multiple approaches will enhance the outcome. So this is my protocol of the multimodality approach, where we do Botox, hormone replacement therapy, shockwave, PRP, a vacuum erection device pumping, and lifestyle modification, meaning we also give them an app to look at diet, exercise, stress, and meditation. So the worse the ED, which is like more severe, the more intensive the treatment. We would do 3 PRP injections 3 months apart, and more shockwave. This is how we're able to get men to restore function with 20 years of having ED, or when ED medication does not work well for them. We're able to restore them function within probably a week as well. And that sexual restoration really is involved the brain, the emotion, the hormone, the nerve, the blood vessel, and the muscle. It's just not just about the corpus cavernosum or the clitoris. It's really involving all multiple system, and that the brain is essentially the largest sexual organ. It starts in the brain, or nothing will go below the belt at all. So in conclusion, sexual restoration is really about relationship, right? In the end, that's what it's all about, is restoring the intimacy, the love, the relationship that important for us at this point. And I've been called the marriage whisperer because I've saved so many marriages. I was on the brink of divorce, that once we restore sexual function again, even in the man, it really binds the couple again. So that's the end of my conclusion. If you'd like to have any more questions either today or afterward, you can connect with me on LinkedIn. Okay, let me stop my sharing.
Thank you so much, Dr. Truong. That was such invaluable information on male and female sexual dysfunction, why PRP, along with other treatment modalities, are very viable treatment options through a review of the clinical literature that you presented. So thank you so much for that. Before we turn things over to Dr. DeMers, just want to remind you guys that there is the Q&A section. Go ahead and load your questions in. This is your chance to ask whatever's on your mind with these treatment options. But with that said, go ahead and take it away, Dr. DeMers.
Great. Thank you so much. Okay, if you can just let me share, that would be great.
Dr. Truong, I think you're going to have to maybe make her a host to let her share. It's not letting me do that.
How does she do that? Okay, so While we are getting this sorted, I will get started. This is a pretty quick and easy discussion of how this we've heard about all the science, and now we're going to go ahead and hear a little bit about business. So let's go ahead, and I'm just going to go ahead and move this down. All right, so we'll just start from the beginning. Okay, can you see my slides? All right, so here's where the kind of the rubber hits the road. Dr. Truong has been, that was a whirlwind of education. But what I want to talk about is, how do we get the patients who so desperately need these treatments to then feel confident to pay for these services that are not covered by standard insurances. So what we can say is, we love the science. She gave us like 1,000 references, which is fantastic. But now what do we do? So I think some really easy ways to think about this is we're going to talk a little bit about practice audit, equipment acquisition, patient selection, how do you market to your list, and then including your packages, just like Dr. Truong has shown, packages are really helpful to enhance value for our patients. So don't worry, you've got this, right? If you're already providing cash services or cash services outside of insurance, like laser hair removal or pellets or hormones or weight loss or aesthetics or nutraceuticals or even braces or anything that's not covered, you are already set up to be able to do this easily. And so really, even if you are an employed physician, which there's a lot of people who are employed, you can now make a small micro practice outside of your standard practice to be able to provide these really important services for your patients. So number one, how do you decide what equipment to choose? Number one, we want a quality system with a high platelet recovery, super efficient 10-minute spin, and then some really cool protein harvesting capabilities as well. This benchtop press, which is the Apex benchtop press, really helps for customizable injection opportunities. When you're using this for sexual wellness, you may want to have a different output than for injections for intra-articular or joint-based services. And so this platform allows you to do all of those things by customizing the injectate possible. And then obviously our output gives very high platelet concentration opportunities to stimulate the repair at a cellular level. So what about patient selections? And I think, Dr. Truong has given us really great ideas of who might be patients. And there's more than you think. Are these the guys that are having some depression? Are these the guys that are maybe having some cardiovascular risks? Have we even talked to them about their sexual health? Probably not. What about women? 40% of women have urinary incontinence, but it's this dirty little secret that nobody talks about. And so if you don't ask, you won't know how many people are severely affected. And the good news is that these therapies are really good. So how do you identify the ones who have great outcomes? For those patients who have mild to moderate urinary incontinence, for those patients who are on the lower end of the severity score, these patients are going to do great with PRP and regenerative sexual health applications. So, I think what we want to do is just make sure that you outline when you're talking to your patients who these treatments are for, and who they're not for. If you have grade 4 prolapse, PRP is not going to treat that, right? If you have angina every day and ED, maybe that's not the first thing that we're going to think about. Maybe we should get your angina under control and address some of those more severe disease states. But for those mild to moderate disease states, these are game changers for these patients, and it really can change your lifestyle and your quality of life. And I always hear this, but no one will pay for this. And really, honestly, it really is about providing value. So make sure you offer these services to your current patients. Start talking about it, saying, hey, I just heard this on this webinar that 40% of women have urinary incontinence, or hey, I see you're on 3 cardiac medications. I just saw this webinar about sexual dysfunction. And has anyone talked to you about your risk for ED? So definitely identify your target market, who those patients are, who you are looking to treat. Create some informational, educational brochures highlighting the benefits of the treatment, the safety of the treatments, and then how to identify and make sure that they know how this solves your patient's problem. I always tell people, you don't sell the bridge. We as physicians are great about saying, well, it does this and this, the PRP has this many platelets and it does this and it's this concentrated. But when you're driving to San Francisco, over the Golden Gate Bridge, you don't really care how many rivets it has and how many sections of concrete and how many tons of steel it was made of, because you're using the bridge to get to San Francisco. You want to know about the destination. You want to know that this is the way forward to the destination. And so when you're talking to your patients about these treatments, the treatment is the way to the destination of solving ED, of solving their urinary incontinence, so they can go work out and they don't have to worry about whether they're going to, pee or need a pad to go to jump on the trampoline. And so really highlighting the benefits and talking about the destination, what this treatment is going to afford them, is going to be really important. And I'm sure Dr. Truong will share this, and I'll share this too. People pay for this. People want to be better without pills, without these expensive treatments, or these treatments that don't work because they don't actually address the root cause of why this is happening. So consider these packages to enhance value, not only for your patients, but it really does help to kind of package it all together so it's a one-stop shop. And you don't have to picksy choosy, oh, we go to this person for this part and this person for this part. If you can be a one-stop shop for your patient where you have all of the answers for the problem that they're bringing to you, that is really quite valuable to our patients. So what you don't need is fancy equipment, more staff, an office remodel, an address in Beverly Hills. People always think, whoa, I need someone, I don't live in a wealthy neighborhood. People aren't going to pay for this. And that's just not true. Patients will pay for value. And if they believe that this is going to get them where they need to be for their quality of life, they will pay for the things that they need. So thank you so much. If you don't offer this service to your patients, they cannot say yes. If you don't talk to your patients about these issues, they can't say that they are in need of these services. So please breach the options. Let them know that this is something that you are considering or that you offer, and offer it to patients. You would be surprised at how many patients are looking for solutions just like this. So thank you so much. I think what we'll do is open that to questions and answers. I'll stop sharing my screen. Let's see
had
here.
a couple of questions that did come in, and I think a great segue from what you went into as far as cash pay and patient identification. We did have somebody ask, what is the learning curve for confidence in patient selection and technique? If you can expand on any of that.
What was the question? What was the learning curve for confidence?
The learning curve for confidence and maybe selecting the right patient, how, who these patients are, identifying them. And
Right. So that's a good question. I think that patient selection is everything, right? Like what everything that you do as a doctor, we also want to make sure that there's no other psychological component, especially when you're talking about sexual health, right? Is it a physical problem, or is it more psychological problem, right? But luckily, 90% of sexual dysfunction is physical. It used to be the reverse. And then in the 1970s, they thought that ED was psychological. It was all in the guy's head. And that even now, even women sexual dysfunction is considered, psychological as well. But we know now that there is a physical cause to that. So when you're evaluating a patient, you want to discern that. So there are validated questionnaires that you can give to the patient. This is what I do when I do an assessment, is that I give them the SHIM ED score, which is 5 questions where they answer that. And for female, is a female sexual dysfunction questionnaire, the validated questionnaire, and it's scored. So you can take the answer and get the total score. And in there, it also asks questions regarding psychological origin questions as well. And then, of course, you evaluate using your clinical judgment when you're examining the patient and correlating with their comorbidity, right? If you're seeing a man over 50 and he's obese and has high blood pressure, pre-diabetes, and low testosterone, yeah, I mean those are a reason why he may have ED. Same thing for a woman. If a woman is over 50, her hormones is decreasing, and there are 4 pillars to sexual health, which is diet, exercise, and stress and sleep. If they are not balanced, it will also affect sexual health, the physical part. So it's all about comprehensive assessment and using the questionnaire and base it upon that. But like I said, 50% of men have ED over 50, and 43% of women over 50 have problem as well. And with the confidence, I'm not so sure what the person is talking about, procedural confidence or more assessment confidence. So I think I was leaning towards more assessment, as in, whether you can do these procedures with PRP or not. Definitely need to get trained on the procedures. And Lauren, you were in my office, that when I process PRP, it's a lot of volume, but we concentrate it and inject it in a very targeted area. I hope I answered that question.
Yeah, that was fantastic. Thank you. We did have somebody that had asked a question about using PRP in conjunction with shockwave. Is the effectiveness of either modality increased significantly by using both at the same time? And on the flip side of that, what are the success rates of using them individually?
Right. So I presented to you the study of using it individually. All right. And again, success rate is based upon patient selection. You gotta make sure you select your patient appropriately, and that you always give them the questionnaire before treatment and during treatment and after treatment, so you can follow along the improvement. Oftentimes, patient won't remember what they eat for breakfast yesterday. How would they even know the improvement? So follow along objectively. And the effect of so I given you the improvement of just one singular modality, but imagine if you combine that with PRP and shockwave and hormone replacement therapy and lifestyle modification. It's gonna quadruple or 5x the rate of improvement. So that's why we do that. That's why we combine the multiple modalities, so that way we can be an Amazon of sexual restoration. What do I mean by Amazon, right? I mean, yesterday I ordered a lotion that was at 10 p.m. It arrived at my house today by the time I got home from work. You know, that's why I mean, Amazon is a multi-billion-dollar company, right? Because I get things fast. We are in the world now where we want things fast. We want result and fast. So that's why I add in the multiple modality, so that way the improvement can be seen quicker and it lasts longer. So if you add multiple treatment option in, you'll get a quicker result, lasting longer, and also you can package it together. It's all about packaging, because if you don't package it together, let's say you just do PRP alone, well, the patient's gonna go, well, I'm just gonna go to the guy 10 miles down the road that did PRP for $1,000 less, because they're really not comparing apples and apples. For what I do, I charge probably the highest in my region, anywhere, and I'm proud of it because I package it and I add premium services into the package, so that way they get everything that they need to restore function again. There's no a la carte or anything.
Okay, great. With that said, in what you're offering, when you have, say, somebody that is a pain management physician, how do they justify kind of going into this urology arena and starting to do sexual wellness?
Right. Well, you know, it's actually aligned. So if you are doing musculoskeletal treatment, you know that, yeah, I just presented to you 50% of men over 50 have ED. And if they already have arthritis, and they're seeking you for help because they want to be active, right? I mean, they're 60 or 55, they want to be active again. So you already know that 50% of them have sexual dysfunction. You just kind of ask them questions that generalities such as, you know, how are things going in the bedroom? And that will open up the doorway to that what they can tell you. And that so I see it as an alignment, an extension of a pain management practice, because if you're skilled enough to do an injection to the knee, the hip, or the spine, you definitely are skilled enough to do injection in the corpus cavernosum and the penis, because that's soft tissue. You don't need fluoroscopy. You don't need ultrasound for the injection. And it's soft tissue. There's really, except for injecting right at, 12 o'clock, and right at where the urethra is, you just inject along the, between, at 3 and 9 o'clock. The corpus cavernosum is the most safe area you can do. And so it's an extension of your practice, and it's easy to integrate because the patients are already there in your practice. All you have to do is ask them how the sexual functioning is, and then present to them that, hey, now I can help you with ED for this, and you can do it at the same time that you do the extremity injection. I've oftentimes do the PRP injection to the penis, while at the same time I'm doing the knee as well. So so I package that together. So it definitely it should be an extension of your practice if you're doing pain. If you're not doing sexual health, you are definitely missing out on potential revenue stream that is it currently in your practice, and you don't even need to get new patient for. The patients are already in your practice. And I mentioned before that patients are not discussing this with their doctor, and they're certainly not discussing it with their pain doctor. But I oftentimes, like, I'm a pain management doctor myself, and I've never asked about sexual performance. And when I start asking about it, the floodgate open, and they're like, oh my God, I'm so glad you asked me about it. So it's a very, very common problem that is underserved. And if you are thinking about doing sexual health, you're really doing your patient a service.
Great, great. Thank you for that. I know we're coming up on our hour, a little bit over it. We do have a couple questions. I'm just going to go on to one more because there's a couple people that asked the same question. How do you determine the price that you charge for your treatments? I think you said you package everything together, but somebody that's kind of just going into this, where do they start?
Well, you don't care what people are charging in your community. I believe that you should charge what you're worth. All right. And so the last thing you should do is, oh, what the guy in my community is charging, and I'm going to charge a lower. Absolutely not. Never raise to the bottom when you're charging. Just you should have an idea. In fact, my prices are the highest, and I start high, but like I said, I add in more stuff. But you can start with, let's say you want to do PRP injection to the penis, you can add supplement with that. Let's say you don't have a shockwave machine, you can add supplement in there. You can do coaching with diet, and I'll tell you now, a Mediterranean diet. Tell them to eat a Mediterranean diet and exercise. Tell them to exercise and sleep and stress reduction. So you can offer that as a package to your PRP injection. So that is how, and whatever the guys in your community that may be doing PRP injection for the penis, charge, I would say charge twice as much or 3 times as much, because if patient is paying $1,000, they can pay $3,000, right? If they see the value and the outcome, as Ariana was saying before, that you want to sell the result of the treatment, not the techno babble what PRP is. I mean, I charge patient $12,000 for the treatment that I just presented to you for ED, but I've never explained to them what PRP is. All I say is these little stem cells from your blood that's gonna help you restore function again. I don't go into the techno babble, because oftentimes doctors will spend time with talking about the features and the techno babble when you really want to sell the result. The result is you're going to get function in about a week, and you don't need to take Viagra. You're going to have you're going to restore your relationship with your partner, your wife again, and that's what they care about.
Absolutely. Absolutely. Well, thank you so much. That is definitely all the time that we have this evening. We want to ensure that we're respecting everyone's time. We did want to announce that we are now offering monthly Sunday labs for lipoaspirate and bone marrow harvest training, as well as PRP and protein concentrate. It's a fantastic opportunity to learn more on advanced technology from Dr. DeMers. And best of all, there's no charge to register. We just ask that you RSVP at least 1 week in advance. And thank you to our panelists. Dr. Truong, you are greatly appreciated for the fantastic insight you provided tonight to everybody on the call. Dr. DeMers did have to hop off right at 9 p.m. Eastern. So thank you to her as well. And thank you to everybody that has joined us here and made this an interactive session. If you guys are interested in Apex's PRP system or products, please scan the QR code you see on your screen, and we'll ensure a member of our clinical education team comes to you with the necessary supplies for patient treatment. And with that said, thank you again, Dr. Truong, and to everyone here, and have a great night.
Thank you.